Before any psychological healing can begin, a person has to survive. In addiction treatment settings, clinical work pauses for physical safety, a reality that becomes especially urgent when substance use intersects with intimate partner violence. When active violence is present in a client's life, standard therapeutic approaches change. Joint or couples counseling, for instance, is contraindicated. Bringing an abuser and a survivor into the same room to talk openly often provokes retaliation the moment they leave the building. Instead, the counselor coordinates with specialized domestic violence advocates to build a safety net. This process follows the survivor's lead, respecting their autonomy and avoiding a forced timeline. There is a specific legal boundary here, too. If children are involved in or exposed to an abusive situation, the counselor must activate mandatory reporting obligations to Child Protective Services. Statistically, the moment a survivor attempts to leave an abusive situation is when they face the highest risk of being killed. During this window, the counselor focuses on securing immediate physical safety and navigating the exit carefully to avoid escalating the danger. That same focus on survival applies to the other acute physical threat in addiction environments, the medical emergency of a drug overdose. Reversing an opioid overdose requires immediate chemical intervention. Counselors equip their clients and their families with naloxone nasal spray, putting the medication directly into their hands. This is vital for individuals leaving a detox program, residential treatment, or incarceration. Because they have been without the substance for a period of time, their physical tolerance has sharply dropped, making a previously standard dose highly lethal. Because of that severe vulnerability, care plans for these clients include active training, walking them and their support networks through the specific steps of an emergency response. Knowing how to recognize the shallow breathing of an overdose, administer Narcan, and summon emergency care effectively expands the counselor's role into acute medical response. Once physical threats are managed, the focus shifts to the internal clinical environment. For treatment to be effective, the client must feel psychologically safe enough to admit to a return to drug use. Historically, treatment centers often responded to drug use with discharge or penalties. However, treating a return to use as a moral failure drives people away from care. Modern practice treats a lapse as a neutral clinical event, used to inform future treatment. This flowchart illustrates the abstinence violation effect. A minor lapse in a punitive environment creates intense guilt, accelerating into a full collapse. An immediate, non-judgmental response interrupts this chain reaction. By re-engaging without anger, the counselor redirects the lapse toward a learning opportunity. Removing shame from the room converts a dangerous mistake into clinical data. The counselor and client analyze the specific triggers that led to the lapse and use that information to strengthen the treatment plan. That analysis works because relapse is a gradual, trackable process with distinct phases, meaning it can be interrupted before a substance is ever picked up. The process typically starts with subtle emotional warning signs. A client might begin isolating from their social circle, skipping meals, or sacrificing their sleep. If those emotional signs are ignored, the client enters a mental phase characterized by active craving. They begin romanticizing past drug use and bargaining with themselves about using just one more time. To counter this, a counselor helps build a concrete relapse prevention plan. This involves identifying the specific environments or moods that put the client at high risk and establishing exactly who they will contact when a crisis occurs. For justice-involved clients, those warning signs look different. A prevention plan here addresses a return to criminal thinking patterns or reconnecting with antisocial peer groups. While discussing prevention is a start, active rehearsal changes behavior. A client needs a personalized, practiced sequence of actions so that when a craving strikes, they move immediately from thought into a predetermined safety response. Creating a safe environment for the client is demanding work. To function effectively, the counselor requires their own professional safety net. Counselors must establish warm, active referral relationships with medical providers, 24-hour crisis lines, and domestic violence services long before they are needed. After a crisis, detailed documentation protects the client and the agency. Furthermore, debriefing the event with a clinical supervisor helps protect the counselor from vicarious trauma. Ultimately, the single most influential tool in navigating a crisis is the counselor's own physical and emotional posture. In any clinical crisis, a panicked professional cannot stabilize a panicked client. A counselor's high arousal level only serves to validate and amplify the client's distress. Calm is equally contagious. Effective crisis intervention relies on the internal stability of the professional. When the counselor remains regulated, they provide the external structure the client needs to restore their own capacity to think clearly.